Okay. So how to make the diagnosis? Because I didn't talk about frequency between the difference between occupational, the work-related asthma, they have occupational asthma, and 20%. This, you know that already. So diagnosis. The first question, is it an asthma related to work? What is the responsible agent and what is the severity and the control of the asthma? First, the clinical history. Okay, so you have to talk about the past and current workers' job duties, the substance that material used at work. Usually, it's very often that the patients, they don't know what they are, to what they are exposed. For example, the patient who are working in a factory, car makers, and they don't know to which real products, all the different products they are exposed to. They don't know very well. Do they wear protective devices? Did they change their position, their exposure? The workplace environmental condition. For example, they could exposed to isocyanates, but in fact now they are far from the high level of isocyanate, but in fact they are still exposed. It's exactly like about the flowers. They are taking care about flower, but they are the chemicals they are exposed to the chemicals too. And the date of the last exposure and current job. Of course, for occupational doctor, it's very well known. You need to take care about rhinitis and skin test, because usually the patient said, oh yes, I have problem with my skin for more than 10 years, but they didn't pay attention about that, or they have rhinitis and they consider it's not a problem. The starting job, the pre-existing asthma. This is very important because for pre-existing asthma, it's a work exacerbated asthma. And as I told you before, it's very important about the future of the worker. The duration of employment at current job before symptoms, so the latency period, or the accidental exposure. The relation for symptom to work exposure. So this is, sometimes it works very well, sometimes it doesn't work. Immediate at work waste, the delayed onset, 4 to 12 hours after starting work, after coming home. This is very important, this is very important, because it's very often that the patient said, okay, I have asthma when I'm back home. It's the late phase reaction, not the immediate. And this is very often with low molecular weight agent, the patient describes symptoms at home and not at work at the beginning. And so you can have also biphasic symptoms, immediate, then they recover, and then late phase reaction, 12 hours after, they have symptoms. And also you have to ask the question, when you are at work, do you have symptoms? But how long does it take to take the symptoms? This is the first part. But when you are off, when you are on vacation, how long does it take to be completely, to be cured about all the symptoms, to be okay? Also, that's very interesting, because you can see that gradually the times necessary to have the decrease of symptom increase. You said, okay, I am off my job for 8 days. At the beginning, within 2 days, it was okay. Now it takes 1 week to be okay. The overlapping, what is the value of all the questions? If we compare to the specific inhalation challenge, that means the gold standard, you know, there is the value of the interrogation was 53%. So the chance to make a real diagnosis of occupational asthma just with the question, the interrogation, is 53, and for the low molecular weight is 47. So it's not, of course, it's very important to ask question, but it's not only question. This is very important question. We think nasal symptoms, ocular itching at work, positively associated with occupational asthma with high molecular weight. I told you when it's high molecular weight, rhinitis or conjunctivitis, atopy. Loss of voice, negatively associated with high molecular weight. And this is loss of voice. This is important. I need to, sorry, Diana, but you will, but it's very important. You need to ask the patient, do you have your voice? Did your voice change when you are at work? And if they say, oh, yes, yes, my friend said, oh, yes, I have a strange voice. And this is very important because you can have a laryngeal spasm. And this is an equivalent with asthmatic. We perform a study with in asthmatic women taking inhaled corticosteroid, and 60% of them have dysphonia and functional dysphonia. That means that the larynx, there is a spasm of the larynx. And this is typical for asthmatics. Okay. Now, is it related to work? So this is important that the doctors, the occupational doctor is very important. You have to document it. And for example, if it is a pulmonologist or allergist, well, first the patient, he has to be in connection with the occupational doctor, and the occupational doctor can say, okay, he's exposed to this different product. So the exhaustive list of agents, this is also, yes, you have a European Academy website in which you have all the different products, and you try to also, it's very helpful to know to which pollutant the patient is exposed. And this is the collaboration with occupational physician is very, very important, of course. And I think it's the problem is that the list of products could be very important. So it's very difficult to try to know that. For example, in France, we have a table with all the different products which could be compensated. So for us, it's easy because we decide, okay, he's exposed to isocyanate, but also to SO2, but also to another pollutants. But we decide to perform study only with isocyanate because we know that if we declare that he has an occupational asthma to isocyanate, he will be compensated. So it helps a little bit to try to find the most the most important pollutant which could induce which is known to induce occupational asthma. So how to demonstrate that asthma is related to work? You can perform spirometry at work, but I think it's very difficult. I don't know what your experience, but our experience is very, very difficult because the patient, it's not easy and very low sensitivity. So because spirometry and FEV1 is the sensitivity is very low. The patient develops symptoms, a lot of symptoms before having a drop in FEV1 at work. Oh, the serial measurement of peak expiratory flow. My English colleagues love this method. And they perform, yes, because it's simple, it's realistic exposure, and it's very cheap. The problem is that the patients are lying. There are very beautiful studies coming from Canada in which they demonstrate that the patient, they fill up the form about the peak flow just before the visit with the doctors. So my experience, I'm not very fond of peak expiratory flow. But for example, in England, they have also a computer. I think there is a program to try to demonstrate that you have an occupational asthma thanks to the results obtained with the peak flow. But look at that. The patient has to perform every 2 hours, 8 working days, 3 days of work. In France, it's impossible to obtain that. That's maybe in England, but in France, I think, even in Alsace, I think it's difficult. This is more important. The change in non-specific hyperresponsiveness, performing methacillin challenge test at work and 10 days after off work. And if you have a change in the non-specific hyperresponsiveness, it's a clue, it's a probe that you have asthma related to occupational exposure. I don't know for you, you can use mannitol or methacholine. In France now, we don't have mannitol, but mannitol is very well. I don't know, do you have mannitol here in Colombia to perform non-specific hyperresponsiveness? No. Methacholine, like us, okay. And you have a change in non-specific. This is very important. But the problem is, if the patient, when you see the patient is off work, that means he's not at work, for maybe 6 months, 3 months, this doesn't work. So because, okay. And this is exactly what I said, that the absence of non-specific hyperresponsiveness not exclude work-related asthma if patient away from work. This is, you must know that. Oh, sputum versus FeNO. Sputum induction is very difficult. It's for research. It takes 3 hours for a technician to analyze. I don't know if you have this experience, but okay, we do that. But there is, for example, in France, there is very, very, very few centers. I think there are less than 5 who perform induced sputum analysis. FeNO is more. Do you use FeNO? Yeah, yeah. FeNO. Poco, sí. Poco centros, sí. 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 FeNO could be useful because it's a marker, it's a surrogate marker for eosinophilic inflammation. It's rapid, it's less invasive. If we perform FeNO, you need to perform, I think FeNO could be interesting. The patient is at work, you perform FeNO measurement the day which the patient is exposed, and then you perform FeNO measurement out of the 10 days after the patient is out of work. Okay. And then also the induced sputum, but as I told you, you can have an increase of eosinophils at work. But this is mostly for research and not. Now, the last question, you suspected what is the responsible agent? And if it is, you think it's an allergen, okay, you are going to look at the positive skin test. But the problem is that there is a lack of standardization between all these extracts. And this is the limit of negative value. If you have a negative skin test, it doesn't mean you could have an allergy to wheat flour with a negative skin test because the quality of the extract is not good. And for flour, it's not so bad. For the bovine animal dander, it's a good negative predictive value, negative IG. So this is skin test and IG. You can increase your sensitivity of with the skin test and the specific IG. Just the skin test. This is a paper we were in the group about the quality of the extract. Is about bakers. It's the quality. All these commercial extracts, and you can see that the level of protein could vary. And the level of antigen, look at this, 21 versus 2070. So it's completely different. So you must be very careful about the quality of the skin test. And this is a real issue, particularly for us in France, because we have less and less and less skin test extracts. About specific IG, for latex, you have a lot of recombinants. You can use, of course, the specific IG against latex, but also you can use recombinant. And you know that there are some who are mostly more relevant. RBV 3, 5, and 6 are more relevant than HBV 8. 3, for example, LTP, 3R14 for the Baker's asthma. We never found any positive patients in all our series of Bakers in France. But I know that in Spain, I think it's Quirce. No, c'est Sastre. It's Professor Sastre found a positive for 3R40. Okay. And then the specific inhalation challenge. This is our chamber in Strasbourg. It's an old one. Now it's more than 30 years. And this is in this chamber, the patient can, for example, if it's a hairdresser, he can perform the coloration or use the bleach for the decoration. The baker, they can use the floor. And for example, if he's a carpenter, he can work with the wood and so on and so forth. We know the air exchange per hour, the ventilation, and here the patient is here, the nurse is here, and every 2 minutes they blow and they obtain the spirometry. And usually a test lasts 3 hours. In fact, the patient is hospitalized for 3 days. First day is placebo, second day is the agent, and the third day we perform a non-specific challenge test after, according to the European guideline that we have done. Okay, here are the recommendations. I don't know, do you have that? Do you have a chamber like that? I think you need to have that. It's not very expensive. It's not very expensive. And it's very, very useful. And particularly if you want to demonstrate that the flowers, all the agent for the flowers, what are the responsible, I think it could be very useful. So occupational asthma should be confirmed by objective physiological in case of allergic, but so it could be used for, of course, for research. In fact, specific bronchial challenge testing is recommended when the diagnosis is not clear beforehand, when cause is new, or is necessary for the management of the individual worker. It must be performed in a center with expertise. This is very important because it could be dangerous. Yes, remember that occupational asthma could be dangerous. It's like performing a food challenge test or a drug challenge test. It's dangerous, so you must be very careful. I say that it's dangerous, but it's according to all the studies that we perform, only 3% have severe reaction. But it's impossible to have a very, very severe reaction performing. You have one death, it's over. So it's impossible. So you must be very careful, but only 3% had severe reaction. I don't think yeah, you will find that because you have my slide, you could, and I think it's all the things. Investigation. So first, history suggestive occupational asthma exposure, confirmation of bronchial asthma, confirmation of work-related bronchoconstriction, confirmation of sensitization if it is the case, a confirmation of the causal role. And that's the point. You have to, is asthma. Asthma is related to work. What kind of agent is responsible for the symptoms? Okay, this is maybe this agent. You have to demonstrate that there is a causal relationship between the symptoms and the agent, and this is sometimes difficult. No, so it is too complicated.